Good afternoon, everyone, members of the organizing committee, Mr. Chairman, ladies and gentlemen. It is both an honor and a privilege to be here with you today at this prestigious ESD 2025 event. I would like to extend my sincere thanks to the committee for the kind invitation to speak. I'm Professor Jaffry from University Hospital, Galway in Ireland, and I'll be speaking on the topic that we are all increasingly encountering in clinical practice: salvage FURS in the context of Staghorn calculi, particularly in the patients where the PCNL is either not possible or inadvisable. Let's explore the role of retrograde intrarenal surgery as a last line, but increasingly.
This session was originally intended to feature semi-live surgeries. However, I've structured it as a blend of outcome-focused results from the staged salvage URS, along with the key insight into the techniques used. Hopefully, you will find it just as engaging and informative as a semi-live surgical session. Stone management has evolved from open surgery as the only option to minimally invasive approaches like PCNL and ureteroscopy, which revolutionized outcomes and recovery. In recent years, advancement in laser technology, flexible endoscopy, and pressurized regulated irrigation have enabled effective retrograde management of even complex stone previously deemed inaccessible. Surgical preferences for stone management has shifted from a one-size-fits-all approach to highly individualized anatomy and comorbidity-driven decision-making. With advancements in endourology, RIRS seems to be taking over. There has been a clear paradigm shift in stone surgery from relying solely on pulverization and spontaneous passage to a more proactive approach involving suction-assisted clearance. EAU guidelines recommend RIRS as a treatment option for stones measuring 2 cm or larger. This meta-analysis shows that flexible ureteroscopy can effectively manage renal stones more than 2 cm with a high stone-free rate. Let's look at the data. While RIRS is traditionally not recommended for stone larger than 2 cm, outcomes from select series shows otherwise. In Trexler et al. Series, staged FURS for large stones demonstrate stone-free rates up to 90%. Of course, RIRS is not without risks. We are dealing with high irrigation pressures, extended operating times, thermal effects from laser lithotripsy, all within a closed system. Urosepsis remains the most feared complication. Open surgery for large kidney stones is now rarely performed and generally reserved for cases when all endourology options have failed. With our aging and comorbid population, we are encountering more and more challenges caring for the patients. Now, these are the classic scenarios where FURS is no longer just an option, becomes the only one. Morbid obesity, horseshoe kidney, pediatric cases, pelvic kidneys, spinal deformities, anticoagulated patients, and urinary diversions. PCNL here is either dangerous or simply impossible. This is a classic no-go for PCNL. Dual antiplatelet therapy cannot be stopped. In this case, we opted for staged FURS, fully aware of the bleeding risks, but it was manageable and successful. This was another case of 3.5 cm stone in an elderly comorbid lady unfit for PCNL. Witness the decimation of this large stone under the lens of radiology. And complete stone clearance was achieved. Even after 2 failed PCNLs, pain and infection persisted. FURS was employed in a staged manner for calcium oxalate monohydrate stone in all cases. This case emphasized the value of FURS post-PCNL failure. Initially, large upper pole stones were addressed. Then the middle pole was addressed. And finally, the lower pole stones and a complete stone clearance was achieved after 4 sessions. You are seeing a pattern: elderly comorbid on triple therapy or anticoagulation.
This is an 83-year-old female with a left staghorn on dual antiplatelets therapy with COAD, ejection fraction of 30%, recurrent UTIs and pain. This is not a contrast study, it's a Staghorn stone. You can see the axis. Watch the decimation in staged FURS through fluoroscope lens. Finally, complete stone clearance was achieved, ending the session at the lower pole and with a check FURS. In this case, we bridged warfarin while continued antiplatelet and performed staged FURS. Sequential staged FURS on each side, tailored to recovery and anticoagulation schedule. These patients may need 2 to 3 sessions, but risks are still significantly lower than open or PCNL in this cohort. This is a 68-year-old female with a symptomatic right side. She has history of atrial fibrillation, CVA, IHD, recurrent UTIs, and is on warfarin and antiplatelets. Staged FURS was performed on the right side and then on the left side, and achieving complete stone clearance on bilateral staghorns.
Now I'm going to share a short video entailing my technique of FURS in large stones.
This slide distills it. When is PCNL not an option? Active infection, bleeding diastasis, pregnancy or unsafe access. Even ureteroscopy has limits. Studies evaluating RIRS for large renal stones show variable primary stone-free rates ranging from 0 to 77%, but with overall stone-free rates improving to 82 to 95% when multiple procedures are performed. And summarizing here again, for stones more than 2 cm. For morbid obesity, when prone position is dangerous or infeasible, RIRS shines. Studies show stone-free rates from 33 to 100% depending on the stone size. And summarizing it here again. Pregnancy, bleeding disorders, anatomical variants, again, RIRS is often the only option. Coagulopathic patients had stone-free rates close to 89% with no transfusion requirements. This paper highlights the expanding role of ureteroscopy in managing complex and previously contraindicated cases such as in pregnancy, coagulopathy, obesity, and anatomical anomalies. Laser physics can be likened by hammering a nail.
The fiber size represents the hammer size. Energy determines the force of each strike, and repetition rate reflects how frequent strikes occurs. Pulse width corresponds to the duration of contact between the hammer and nail. These parameters interact significantly, particularly in closed system where thermal load and pressure dynamics must be tightly controlled. At my institution in Ireland, we use advanced emission laser like the Cyber Holmium 150. Settings like vapor tunnel, master pulse allow us to fine-tune the ablation and retropulsion profiles, especially when targeting harder stone. Advanced modalities like vapor tunnel and virtual baskets offer superior control and minimal retropulsion, while bubble blast may be reserved for situations when maximum fragmentation is prioritized over precision. We're going to examine vapor tunnel. When the holmium YAG is fired in an aqueous environment, it emits energy at a wavelength of 2100 nanometers, which is strongly absorbed by the water. This high absorption creates localized vaporization of fluid at the tip of the laser fiber, forming a vapor bubble, which when pulses are delivered in rapid succession and at a high enough frequency, these bubbles coalesce and persist momentarily as a stable vapor tunnel. This tunnel allows subsequent laser pulses to pass through the vapor tunnel with minimal energy loss, as they are not absorbed by the water en route to the stone. This means increased transmission of energy directly to the stone, reduced retropulsion, improved precision and fragmentation efficiency. Technical conditions for vapor tunnel formation is to generate and maintain the vapor tunnel at a high pulse repetition rate of more than 40 Hz, low pulse energy 0.2 to 0.5 joules, and use of short pulse duration and consistent contact or near contact between the fiber tip and the stone. Master pulse allows the surgeon to modulate the pulse width. Generally short pulses deliver energy rapidly, resulting in high peak powers and more mechanical fragmentation, and the long pulses delivers energy more slowly, leading to lower peak powers, reduced retropulsion, and more controlled dusting stones. These are the indications for salvage FURS. My technique for salvage FURS would include staging, typically 2 or more sittings. Pre-stenting usually helps. Lower pressure irrigation reduces septic risk, and using suction access sheath facilitates the fragment clearance. This large prospective multicentric study by the EAU urolithiasis section found that using a flexible and navigable suction ureteric access sheath significantly improves the outcome at 30 days post RIRS. We have incorporated suction-enabled access sheaths to enhance visibility, reduce pressure, and passively clear the fragments. These tools reduced operative time and infection risks. When staged appropriately, stone-free rates exceeds 85%. Complication rates hover around 10%, most of which are Cleveland Endo 1 to 2. No mortalities in the series we have reviewed. The key is patient selection and meticulous technique. Compared to open surgery or ECIRS, salvage FURS offers lower morbidity, shorter stay, and fewer bleeding complications. In the past, our options for managing complex stone were limited to open surgery or PCNL, effective but often high risk. Today, we stand in a more nuanced era where flexible ureteroscopy, laser advancement, and suction technologies allows us to treat even Staghorn stones in the high-risk patients with safety and precision. And as we look to the future with smarter lasers, real-time pressure feedback, and robotic-assisted platforms on the horizon, salvage FURS will not just be a compromise, it will increasingly become a cornerstone of tailored stone management. Are we truly seeing the end of an era, or are we simply witnessing a redefinition of indications? With salvage FURS and suction-enabled RIRS pushing boundaries, perhaps the question is no longer can we do PCNL, but rather do we need to?
Thank you for your attention. I am happy to open the floor, whether it's around techniques, patient selection, or outcomes. I'd love to hear your experience and debate the nuance with you.